Hello, my name is George Bartley. I'm from the Department of Ophthalmology at the Mayo Clinic in Rochester, Minnesota. We're here today at the annual meeting of the American Academy of Ophthalmology and are pleased that Mr. Humphrey Taylor has taken time from his busy schedule to visit with us. I've had the privilege of working with Humphrey on the Board of Trustees of the Academy for the past few years. Humphrey, you've been a trustee of the Academy, a public trustee for the past 15 years. What is your role and why do you do this?
When I was asked to do it, I was told by Dunbar Hoskins and Tom Hoskins, who were running the Academy, so to speak, at that time, that they thought they spent too much time breathing their own exhaust and that they ought to breathe somebody else's exhaust. So they decided it'd be a good idea to have a public trustee who was not a doctor on the board. And I think many other medical societies now do that, but the American Academy was the first medical society to take that decision.
Now, you're British and have several members of your family who have practiced medicine and still do practice in Britain.
And in America.
And in America. Apart from universal coverage in the UK, what are the most important differences between the healthcare systems in the US and the UK?
Wow. Well, first of all, the whole culture is very, very different. There is a much greater sense of social solidarity. Universal coverage has been there since the 1940s and is accepted by even the right wing of the Conservative Party. So it's not a controversial issue. For all kinds of historical reasons, costs have been kept way down in the UK, so they've actually been pretty short of a lot of things until the Blair Labour government did substantially increase spending on healthcare, but they still spend a very small amount compared to what we spend, but they actually deliver now pretty good care most of the time in most places, and they certainly get very good value for the money that they spend.
Why are healthcare costs in the U.S. so much greater than other countries?
Well, it's not because we do more. We don't have more physician visits. We have less than most developed countries. We don't have more days in hospital than most other developed countries. In fact, we have less. We don't do more procedures, or most procedures. We do rather more tests. We actually consume rather less drugs than the average for rich countries. And there was a paper some years ago in Health Affairs, the title of which was "It's the Prices, Stupid," and it was shown that if you actually charge the same prices in the United States that are charged in the other rich OECD countries, that we would spend a great deal less on healthcare. And in fact, George Halverson, the CEO of Kaiser, the Kaiser plans, published a thing earlier this year, in which he said that if we delivered all of the care that we deliver in the United States in exactly the same way that we do now, but we paid Canadian prices instead of American prices, instead of spending 18% of GDP on healthcare, we would only spend less than 12% of GDP on care. So basically it's the prices.
In your research and your work with the Harris Poll, are there other lessons that we could learn in the U.S. from other countries?
Oh, there are many, many, many lessons we can learn, both about how to contain costs and how to improve outcomes. Not that every other country doesn't also have tremendous problems. One of my kind of little cliches is that healthcare systems in all countries are always in crisis, as they always seem to be to the people who live there. If I was to take the big picture, I would say one of the worst things about the American system is its unbelievable complexity. The amount of time spent on administration is about 6 times higher, or the cost of administration is about 6 times higher in this country than in most other rich developed countries. I also think that the reimbursement system that we have here provides a lot of terribly, some people say toxic or perverse incentives. So that's a major thing that I would change. Every country comes with its own beliefs and values, and I don't think you can actually take any one country's system and just transplant it to another country.
Now, you've done research on the use of the internet and online information for patients. What does that research show?
Well, there are two very different things that are worth mentioning. One is that in some countries, doctors and patients talk to each other online a lot. and it's made very easy. In Denmark, all doctors are online to their patients, and the Danish government decided that they wanted to encourage online conversations between patients and doctors, and also telephone conversations rather than having patients come in for a visit. So they actually pay for each telephone call and they pay for each online conversation. And because they thought that online was more efficient than telephone, they pay twice as much for every online conversation as for every telephone conversation. And guess what? As a result, there is a great deal of that, and it saves, I do believe, a lot of visits, and it enables consumers to get very rapid response. So that's one thing. The second thing is that the majority of the American people, a large majority, have actually gone online at some time to look for healthcare or medical information online. And most of the people who've done so say that they have got what they were looking for and that they thought it was reliable and that they thought the search was useful and successful. And about half of these people say they've actually discussed what they found on the internet with their doctor and that this was helpful, that it stimulated a good conversation. Also, we found that increasing numbers of people, about half of all those who go online for medical information, have actually done so at the suggestion of their doctors, who say if you want to find out more about this condition or this medication or this treatment, you could go to this website and have a look at it and find out more about it. So it's a real game changer.
You've said that quality is in the eye of the beholder, quote unquote, and also that many quality efforts resemble the Tower of Babel. Can you expand on those?
Yes. Well, when we have surveyed different players, different stakeholders in the healthcare system, patients, the public, physicians, insurers, hospital managers, policy wonks, demographers, statisticians, public health people, they all tend to talk about different things when it comes to quality. And I would add here that there's sort of a morphing now, to some extent, from just quality to value, which is not just quality, but in a sense, quality for whatever cost is involved. If you talk to physicians, they are very concerned about autonomy. They worry about having happy patients. They worry about administrative inefficiencies and barriers to their being able to provide care, and they see all those as impediments to good quality. The patients tend to be somewhat influenced by the kind of the hotel function. Is the doctor's office nice? Is the hospital have a nice atrium? Was the food good? But of course they worry about outcomes as well, of course. If you ask payers, they tend to worry much more about value and what can be done to contain costs and provide, and they worry therefore about the use of low-cost generic drugs and so on. When you ask people at the Institute of Medicine, they tend to think about the avoidance of adverse events, medical errors, and how to improve quality by reducing those medical errors. If you ask demographers and public health people, they talk about vital statistics, they talk about life expectancy, population statistics really, including one very, very important one which not many people are aware of, which is something called deaths which are amenable to medical care, which really mean deaths which they think could and should have been or could have been prevented by the appropriate medical care. And the reason I mention that is that we in the United States do extremely badly on that. In fact, when there was a comparison for 19 countries, we were 19th out of 19. There's now more up-to-date data on 15 countries, and we are the worst of the 15. And furthermore, we're progressing, improving more slowly than all of the other countries that are listed. So each and every one of these different constituencies, different stakeholder groups, is looking at different numbers, different measures, and so when they talk about quality, there is a danger, as with the Tower of Babel, that they'll actually talk past each other.
Well, let's assume that we could define quality in a way that the various stakeholders could agree on it. In your opinion, are Americans really ready to and willing to pay for quality?
Well, some people believe, and I think with real validity, that if in fact you can improve quality by reducing medical errors, for example, and maybe by delivering more appropriate care, that we would actually substantially reduce the cost of care, everything else being equal. And I think that's almost certainly true. Having said that, we also know from Elizabeth McGlynn and other important published papers that large numbers of people still do not get the appropriate care. So that part of improving the quality of care presumably would lead initially anyway to an increase in the cost of care. What I do believe is that if we could improve the quality of care, and we are doing of course, but the more we can improve the quality of care, the more willing people will be to pay for it. So if the American Academy of Ophthalmology and physicians generally obviously have an interest in seeing more money being spent on healthcare, it'll be easier to achieve that if the quality improves.
So to probe a little further in this relationship between reimbursement and efficacy, clinical efficacy, can we learn from initiatives in other countries such as the NICE in Britain, the QALYS in France, that perhaps could be applicable here in our country?
Well, I think at the broadest level, one of the most important differences, and indeed one of the weaknesses of American medical care, is a lot of decisions about, for example, reimbursement are very strongly influenced by advocacy groups of people who have a financial interest in that. If you look at the debate about breast cancer screening, if you look at the debate about PSAs, if you look at a lot of the currently controversial issues, there are very strong advocacy groups who have a financial interest in administering these tests and so on. So I think other countries do a better job than we do in reducing the power of lobbyists, reducing the impact of those with a financial interest on policy decisions and reimbursement decisions. Therefore, it's easier for these other countries to make what are often tough choices. I mean, I believe that we have finite resources and that we have potentially infinite demand for medical care. Therefore, we have to make tough choices. You know, is it better to immunize everybody, or is it better to take some of that money and use it for neonatal care? You know, and there are a lot of things like that where I think we actually get the answers wrong, partly because of the power of lobbyists in this country.
Well, if you were a benign dictator, how would you change the U.S. healthcare reimbursement system?
Well, let me just say, if I was God and therefore could do anything, and I could start from scratch, I would nuke the present system and I would actually go to a single payer system, which I believe, if you look around the world, tends to be more cost effective than fee-for-service systems, and it's certainly administratively much cheaper. And secondly, I would move away from, well, let me just say, so that's if I'm God, but I'm not God. And even as a benign dictator, I couldn't do that. You can't actually, or you'd have to be a pretty tough less than a benign dictator. So in the real world, even a benign dictator couldn't do that. Therefore, I think you have to go from where we are, build on what we've got, which means to me going to something like the Swiss system or the French system or the Australian system, all of which, particularly the first two, are essentially insurance-based systems like the United States, where there is competition between different health insurers, but which are both highly regulated and price controlled. That would involve, by the way, dramatically reducing the impact of fee-for-service care and moving much more to everything from capitated care to all of the things we're talking about now in healthcare reform, you know, global payments, episodes of care, etc., bundled payments.
Humphrey, I know you have a flight to catch back to New York. We want to thank you for taking the time to visit with us today, and thank you as well for the wonderful service you provide to patients in the United States and around the world through your role on the Board of Trustees of the American Academy of Ophthalmology. Thanks so much.
Thank you very much, George. Thank you.